Great, thanks. Pleasure to be here to talk about my experiences with the collapsed athlete using the Ironman triathlon in Kona as sort of the setting. I don't know how many of you have been to Hawaii for this race. It's pretty intense. It starts with a 2.4-mile swim in Kailua Bay, and typically we have very few problems arising there, but this is followed then by a 112-mile bike out along the Queen K Highway, which you can see from this picture. Most of the route is formed by black lava coming down to the black asphalt with more black lava going to the ocean. And the heat can be quite intense. The heat and humidity here sort of are legendary. And this begins to where we see problems developing, particularly when we have high winds out on the Queen K. That really portends that we're going to have a busy medical tent. And then it's finished up with a 26.2 mile marathon along a similar route, and there's a point where the closer you get to the ocean, the more intense the heat and humidity become, and it's a pretty famous turnaround at the Energy Lab where the heat can just be intolerable in the mid-afternoon. And so I've actually chaired a sports medicine conference there for going on 20 years now and served as one of the medical coordinators in the tent. And through that, experienced a lot of very interesting cases of collapse that I'm going to use to sort of formulate an approach that you can use. And certainly by no means is this just applicable to an Ironman race or really any endurance race. For that matter, I think the principles that I'm going to talk about are very applicable, covering a football match, a tennis tournament, or a track meet, and when you're dealing with an athlete who has collapsed. Now, any of you are interested in coming and attending the conference, it's really a great week. We have some internationally known speakers, and many of you in this audience have spoke at the conference. And then you serve at the end of the week in the medical tent for the Ironman race, and we actually give continuing education credit for working in the medical tent. It's almost like a mini internship and a crash course in dealing with the collapsed athlete. Now, I think really Kona has become the center of where collapse sort of was defined. It's sort of the signature medical issue in the Ironman race. Certainly, a collapsed athlete is one of the most dramatic things that we see covering an endurance event, and one of the most common problems that's come into the medical tent. Now, in my experience, it's often precipitated by problems with sodium and fluid balance. It was really made famous in the 1982 Ironman triathlon with this picture of Julie Moss crawling across the finish line. At the time, Julie was a 23-year-old San Diego State graduate student who decided to run the race as part of her master's thesis. And amazingly, she had been a decent endurance athlete, but she was leading the race coming down the home stretch. And this famous sort of collapse and then crawling was shown on Wild World of Sports. And there's many a triathlete who I've spoken to, when they said, when I saw Julie Moss crawling across that finish line, I knew I wanted to do this race. And that certainly didn't have the same effect on me, looking at that footage. So just to give you an overview of what I want to do in this lecture, I'm going to discuss the evaluation of the collapsed athlete on the field, on the race course, and then talk about some criteria that you can use very practically to determine the potential severity of a collapsed athlete. How sick are they? How worried do I need to be based on just simply your physical exam, the history and physical exam. And then I'll go through the most common problems that we see in the medical tent in Kona and how these are managed and hopefully prevented. And in the end, I'm going to suggest that most of the time these are very predictable and caused by oftentimes avoidable errors in the approach the athlete takes to doing that race. Now, by definition, I would define exercise-associated collapse as the inability to walk unassisted, and it may be with or without nausea, vomiting, diarrhea, volume depletion, cramping. The temp could be high, could be normal, could be low. We've had cases not in Kona, but certainly in triathlons where there's a cold water sim where we see athletes collapse coming out of the water due to hypothermia. And I'm really talking for the most part about metabolic conditions. I'm not talking about an athlete who twists their ankle and collapse as they're running a race. So like any evaluation, you begin with the athlete who's collapsed, and a bit of extremis is take the vital signs. What is their temperature, their blood pressure, their heart rate? Certainly you need to ask yourself, do I need to initiate ACLS? We certainly can see athletes rarely collapsing because of an acute coronary event or perhaps a subarachnoid hemorrhage. Those are very rare, but you always have to be thinking of those in the back of your mind. In my mind, the best sign of the severity of collapse is the athlete's level of consciousness. In my experience, if an athlete is awake, coherent, and talking to you, it's much less likely to be something severe. Where I get concerned is when an athlete is obtunded, he's not responsive, he's talking inappropriately. My level of concern immediately goes up. Simply observing where the collapse occurred has great prognostic significance. Probably 90% of the cases of collapse occur after the finish line, when the athlete has stopped running. And that portends a much less severe etiology of the collapse, as opposed to an athlete who collapses right in the midst of doing extreme effort to get to the finish line. My level of concern goes way up. Important history questions to ask of an athlete who has collapsed and you're evaluating them in the medical tent or on the course is asking about the amount and type of fluid they've taken in during the race. Have they been drinking adequately, and have they been taking in some carbohydrate with it? Have they been taking in electrolytes with it? Those are important history questions and suggest that they may be depleted both either on fluids or on electrolytes, particularly sodium. Have they been passing urine is an important question. In general, athletes who are well hydrated or overhydrated often pass urine, but keep in mind we see athletes with hyponatremia, exercise-induced hyponatremia, often stop urinating inappropriately, even though they are fluid overloaded. Athletes who have been vomiting or experiencing diarrhea obviously are much more likely to be dehydrated because of the loss of fluid occurring there. You want to ask about the amount of carbohydrate. Very oftentimes athletes will collapse simply because of carbohydrate depletion. Often late in the race, they sort of hit the wall or bonk, and may not be unconscious, but they're going to just simply feel like they cannot go on and collapse just because of this loss of carbohydrate. Certainly, recent illnesses or medications can impair an athlete's ability to withstand the heat and may make collapse more likely. And then you want to ask about their race preparation. Have they been adequately training for this race? Particularly in Kona, we see athletes coming from other areas of the country, and they're just not used to that heat and humidity, and they're more likely to collapse than those who are used to it. Your examination comes next, and very important, as I mentioned, the level of consciousness and the athlete's mental status probably is the most important thing in your assessment of the collapsed athlete. You want to assess their state of hydration. Now, the best way to do that is by weighing them. And at Kona, we insist that all athletes have a pre-race weight, and then we weigh them again in the medical tent, and that difference is a good estimation of how dehydrated they are, or perhaps fluid overloaded. If they've gained weight, they've obviously drank too much. If they've lost significant amounts of weight, more than 5% of their body weight, they're significantly dehydrated. By and large, athletes who are dehydrated are going to be very thirsty. Their lips are going to be dry. They often cannot generate spit in their mouth. If you ask them to spit, they're unable to do so when they're significantly dehydrated. If they're fluid overloaded, they may look and feel puffy. Their race wristband that at the beginning of the day was loose has now become tight, and they'll all know if their watch is tighter than it usually is on their wrist. Is a good question. Or any rings they may be wearing, are those feeling tight? That's a sign that they may be fluid overloaded. Checking the blood pressure and heart rate, very important. And if there's a concern about significant dehydration, we often take orthostatic measures, both supine and erect. But keep in mind in these athletes that a pulse of 80 is often a very significant tachycardia. All of these athletes will know their normal resting pulse. Very important to ask them, what is your normal resting pulse? And make your assessment from there. Don't assume that because their pulse is 80 that they are not, that's normal for them. The key in the evaluation of heat stroke is a rectal temperature, and this can be difficult in a medical tent setting, but it's extremely important. You cannot rely on ear or oral temperatures. We've been shown to not be accurate at the high end. If you get an oral or an ear temperature and it's normal, you're probably okay, but you can't trust the upper limits of this. You really need a rectal temperature to make the diagnosis or rule out the diagnosis of heat stroke. It's also essential in these longer endurance races that you be able to check glucose and sodium concentration. Now, based on your history and your physical exam, you can make a quick assessment based on that on the potential severity of the cause of this athlete's collapse. And in general, the cause is most likely to be benign if the athlete is awake, conscious, and alert, talking to you appropriately. The rectal temperature is below 40. Systolic blood pressure and heart rate come down into normal ranges after you've laid them down, elevated their feet within 5-10 minutes. If the vital signs get back to normal, much less likely to be something severe. Sugar, blood sugar in a normal range, sodium in a reasonably normal range, and experience a small amount of weight loss, less than 5%. Most likely the cause of collapse is benign. Now this woman here you can see is exhibiting the absolute sign of benign collapse. We call it the cell phone sign. And when you're talking on your cell phone, it's time to get out of the medical tent and give that bed to somebody else. The cause of your collapse is benign. Now the most common causes, benign causes of collapse include simple exhaustion and dehydration, postural hypotension, extremely common. And this is the classic where the athlete goes across the finish line and collapses, and we'll talk about that. Exercise-induced GI distress, and often accompanying that, significant dehydration, again, generally benign. Muscle cramping, and we see muscle cramping in Kona like I've never seen before, certainly could cause collapse and benign as any orthopedic concerns as well. Now, on the opposite hand, the cause of collapse is more likely to be serious if the athlete is unconscious. There's an alteration in their mental status. Maybe they're confused. I think we all know that confused look when we see it. If they're disoriented, aggressive, acting out inappropriately, could be signs of heat stroke. And that's essential that this alteration in mental status and your armpits are sweaty, you need to rule out heat stroke. That has to be the number one thing on your mind. And if you cannot conclusively, clinically rule it out, you've got to get a rectal temperature. Really, that's the key to doing it. So when you combine an alteration in mental status and a rectal temperature above 40 degrees Celsius, that is heat stroke. And those athletes need to be immediately put in ice water to cool them off. Systolic blood pressure that does not come up with elevation of the legs and rest, heart rate that does not come down with the same maneuvers, that suggests the cause of the collapse is more serious. You also, obviously, in the labs, if you have most often low blood sugar, sodium that's low, and significant weight loss or weight gain, really any weight gain, significant amount of weight gain is abnormal and should suggest to you that athlete is fluid overloaded. You do not want to give them fluids. You can kill an athlete that's already fluid overloaded by loading on more fluids. And we've had cases of death caused iatrogenically by people inappropriately giving IV fluids. So you need to know, if there's any doubt, you got to get a sodium before you give much more than 500 cc's of fluid. The serious causes of collapse, the most common that we see is hyponatremia of exercise. Heat stroke seen less commonly, and in fact in Ironman we very seldom see heat stroke. The race is just so long, they're not going fast enough often to get into that range where they'll develop heat stroke. Much more likely to be seen in marathons than in Ironman distance triathlon, but it can occur. Hypoglycemia, typically it's in a diabetic, where I've seen it in Kona, although we don't have a lot of diabetics that run that race. Bowel ischemia is a rare but potential serious lethal complication if not appropriately managed. And then certainly the other various medical problems, from cardiac arrest to seizures, subarachnoid hemorrhage, all of those things can occur, but very rarely. Now, as I mentioned in my introduction, in my experience, when an athlete collapses in an endurance race, it's often predictable based on their approach to their hydration plan and their electrolyte replacement plan. And typically I see two camps. Either they're over drinking with fluid overload, and often they're swollen, and the most common complication is hyponatremia of exercise from drinking too much. And in fact, we have seen cases where athletes actually develop symptoms of pulmonary edema and congestive failure. We've had to give Lasix often because a medical tent doctor got too overzealous and gave too much IV fluid, an athlete who was already fluid overloaded. On the opposite hand, we see problems related to underdrinking, where they become dehydrated, often more prone to develop postural hypotension and collapse from that. Muscle crampings tend to be worse in the athlete who is volume depleted, as is heat stroke, hyponatremia. Those issues occur on the underdrinking side. Now, critical question is, how much should an athlete drink? Well, I think it's very clear in my mind that you need to try to replace the sweat losses. And every athlete should know his sweat rate. They should go out for an hour and run at a race-based pace, or cycle at a race-based pace in environmental conditions that are going to be similar to the race. Weigh themselves nude before, weigh themselves nude after, and the weight change is a good estimation of your sweat rate. So if you lose a pound, you should be trying to consume 16 ounces of fluid every hour to try to maintain your hydration status. This is very much individualized. It makes no sense to tell an athlete you need to drink 8 ounces every 15 minutes. You cannot use those kind of recommendations. It has to be individualized. Every athlete is different. Now, it's interesting, in the evolution of hydration in endurance races really goes back to the 1950s, where you saw this recurrent problems with hydration errors. Jim Peters in the 1950s was arguably one of the greatest marathon runners of all time. And in fact, in 1954, he held the 4 fastest marathon times in history. And his marathoning career really came to an end back in 1954 at the Empire Games, when Jim Peters came into the stadium leading the race in a very scalding hot day. And you can see him here near collapse, trying to make the finish line.
Where the big stand is, you see, because then the sun was out. And
he says he was trying to actually get in the shade, and that's why he kind of collapsed over on the side of the track. But you see that sort of bent over appearance, running, trying to keep going. That's really very symbolic of an athlete suffering from heat stroke, and we've seen this in case after case.
Even at that moment. And I can remember Mickey saying, "Well done, Jim." And then, of course, I passed.
So I didn't mention that Jim Peters' advice to marathoners back then was that in the marathon race, there is no need to take any solid food at all, and every effort should be made to do without liquid. As the moment food or drink is taken, some discomfort will almost invariably be felt. So that was Jim Peters' approach to hydration in the 1950s, the top marathoner of all time. And it's interesting, Jim Peters only ran typically 1 race a year, maybe 2 races a year, and I would submit that with this kind of a drinking strategy, it probably took a lot out of you and was hard to recover after that. And in fact, after he had that collapse, that heat stroke, he never raced again in a serious fashion. Now, this sort of approach to hydration continued into the 1960s, and Tommy Simpson, the British cycling champ in 1965, said that a Tour de France athlete should drink as little as possible and with the liquid not too cold. It is only a question of willpower. When you drink too much, you will perspire and lose your strength. 4 small bottles on the long stage of the Tour, it's frowned upon to drink more. And I think we all remember the tragic case of Tommy Simpson in the 1967 Tour de France in this climb up Mt Ventoux, which was done in what is described as cauldron-like heat. And you can see Simpson, 50 meters from the summit of Mt Ventoux, struggling to catch the leaders, when he suddenly begins to wobble and then falls over. And his famous last words as he was dying were, "Put me back on my bike." And you can see them, multiple attempts to get him back on his bike, followed by his collapse onto the side of the road in Mt Ventoux, doing CPR, a helicopter coming, taking him to the emergency room. Tommy Simpson died that day on Mt Ventoux from heat stroke. And I think we're also all aware that later on it was revealed that he had been using amphetamines in many of the cases of heat stroke. We've seen that as a complicating factor. But no doubt, problems with a flawed drinking strategy, I believe, were contributors as well. And it's interesting, there's a memorial to Tommy Simpson on Mt Ventoux, and the athletes ride by and often leave their water bottles on his monument, almost as a testament to a problem drinking strategy, in my mind, that likely contributed to his death. Now, this idea that we can give a one-size-fits-all message on how to hydrate does not hold water. It simply does not work. You have to understand the extreme variability that we see in athletes. Now, an athlete like Mia Hamm, who sweats 700 milliliters an hour, does not have to worry about hydration issues. She can drink when she's thirsty. She can probably not drink the whole match, and it's not going to bother her. She is not losing enough sweat in a 2-hour football game to become significantly dehydrated. But when you begin to talk about most of these endurance athletes, like Chris Legh, one of the top professional triathletes, who I'll talk about later in some of his issues, he sweats about 2 liters an hour. So if Chris Legh waits 30 minutes to start drinking, he's going to be a liter behind. And when you talk about an athlete like Adam Kennedy, who's a professional tennis player, he sweats 5 liters an hour. If Adam Kennedy waits 15 minutes, he's a liter behind. He has to drink on a regimented schedule to just simply stay up with his losses. So this idea that we can tell people, only drink when you feel thirsty, don't start drinking until you feel that, it's not going to work for these athletes with very high sweat rates. They need to pay attention to this or they're going to have problems. So let's run through and talk about the common causes of collapse that we are likely to see. Oops, went the wrong way there. Dehydration, probably the most common contributor to an athlete collapsing, and certainly if the dehydration is severe enough, you may see collapse with that alone, just simply due to a decrease in circulating blood volume in very severe cases of dehydration. But in my experience, it seems to increase both the risk and the severity of all these other causes of collapse when an athlete becomes dehydrated. Now, an athlete who is significantly dehydrated, as I mentioned in my introduction, is going to be very thirsty. Their mouth is going to be dry. They're not going to be able to make spit. The best measure of dehydration, as I mentioned, is get their weight. And you have to have that pre-race weight compared to the weight after they finish. That loss is a great estimation of how much they are dehydrated. Those that have lost more than 5% of their body weight are significantly dehydrated, and you may want to think about putting an IV in those and giving them some fluids. When they're significantly dehydrated, you typically see increases in heart rate, a decrease in blood pressure. Often there'll be more orthostatic changes. When they're severely dehydrated, the skin actually may become doughy and actually tent when you pinch the skin when they've lost a significant amount of fluid. The treatment should always begin with oral rehydration, but athletes, in my experience, who are significantly dehydrated, and those certainly who are nauseated and vomiting and can't take fluid, you're best off giving them some IV fluid. Now, this has been a bit of controversy. Who should get IV fluids in an endurance race? And I tell you, after working the medical tent in Kona for many years, I've become much more liberal with IV fluids. When I have a professional triathlete come in and tell me, listen, I've done this race 10 times. If you give me a liter of fluid, I'll be able to go out to dinner tonight. I'll feel much better. I'll sleep better. How do I argue with that? It's, when they have been through this and they know if they get IV fluids, they feel that much better. What is the harm in giving them some fluid? Well, the harm that you have to be concerned about is if they're fluid overloaded. You could kill somebody again who is fluid overloaded, and then you add on more fluid. So you need to get a weight. You're not going to do that with 500 cc's of fluid, but you don't want to give a couple liters to somebody who's already fluid overloaded. So you have to make sure you understand the weight change in their hydration status. Typically in Kona, we just simply use normal saline, and obviously we like to combine that with a little bit of carbohydrate after the race. Now, one of the most common things we see in the medical tent is GI distress, upset stomach during and after the race. Often they have nausea, vomiting, diarrhea. Often it's blood tinged, a little bit of bright red blood in the vomitus, or the diarrhea is common. And we suspect that this is caused by this intense diversion of blood away from the gut to the working muscle. And when you combine this with an athlete often who is taking in too many calories and too many food substances that are complex to digest, this combination to me is predictable that they're going to end up with an upset stomach. We also know that during that intense activity where the blood is being diverted away from the gut, that we see a release of toxins into the bloodstream during exercise, endurance exercise, that seem to precipitate nausea. Again, in my experience, the athlete is taking in too many calories, too much food is often the one that's a setup for a GI distress. Now, at the end stages of this, we can see, because of that intense diversion of blood from the gut, actual cases of bowel ischemia. And one of the most famous is shown here in his photograph, Chris Legh, that actually took of him in the tent in Kona when he collapsed, related to a case of bowel ischemia. This is a clip from the 1997 Ironman of Chris Legh. It was sort of made famous in a Gatorade commercial.
Mind and body can literally come apart. October 18, 1997. Chris Legh has covered 140 miles and can go no more. It's over just 50 feet from the finish line. It's cruel. And that's the deal.
So there's much more to the Chris Legh story than that. And Chris has become a good friend, and certainly he's given me permission to talk about his medical conditions stemming from this incident. And if I've had a chance to look at the entire footage, which is much more graphic. They obviously edited it down, that little piece that appeared on the Ironman show. But during that race, Chris was unable to keep down fluids from the start of the bike. And at the time, he was actually in 6th place, and he was really about 50 meters from the finish line. And you can see this picture of Chris that does not look like them. He's obtunded, bloated. When he collapsed, that's me actually on the stretcher bringing him into the tent. I cared for him in the medical tent, and at the time, we gave him some medications for his nausea. We were using Reglan at the time, believe it or not, back then. We gave him a couple liters of IV fluids, and after 4 hours or so, lying in the med tent with his feet up, Chris was feeling much better, and he was actually drinking. He ate some fruit, and said, I feel good and I want to go home. And he was staying in a condominium a couple miles from the finish line. And that night he began to feel just worse and worse nausea. The next day he developed increasing abdominal pain and fever and chills. And by the next afternoon had to go to the emergency room at Kona Hospital. And they did an exploratory laparotomy and removed 16 centimeters of infarcted bowel. So again, just this intense diversion of blood away from the gut resulted in ischemia that caused his bowel to die. And amazingly, Chris has had 5 surgeries since then. He continues to race in endurance races because of adhesions since that initial surgery. It's been quite a road, but he's actually still competing. Now, postural hypotension is probably the most common cause of collapse, and this is the classic one that occurs in athletes who collapse after the finish line. Rarely, while this can be dramatic, rarely is it serious and almost never needs to be hospitalized or any significant evaluation. And the cause here is related to blood pooling in the skin and in the lower extremities. You know, with each stride, the muscles in the lower extremities act as a second heart, and they help pump that blood back up centrally. So all this blood is being pushed to the legs to supply the working muscle, and when that muscle stops working, you lose that second heart. The blood pools, the athlete stands there, they become lightheaded, and they often keel over. That's why it's so important in athletes who have finished an endurance race to keep them moving. You got to keep them walking, and if they start to feel a little lightheaded or dizzy, they need to lie down and put their legs up. That's simply the treatment for this. Now, in my experience, athletes who are significantly dehydrated are more likely to suffer postural hypotension because there is a decrease in circulating volume. There is no evidence that this is a warning sign for heat stroke or that it's going to progress onto heat stroke. This is really not a heat illness. It's entirely related to shunting of blood away from the brain to the lower extremities, and then that pooling down there and not getting back to supply the brain. So on examination, these athletes' rectal temperature should be normal, or certainly less than 40 degrees. Once you lie them down, elevate their feet, heart rate should come down, blood pressure should go up, and that's simply the treatment. Allow them to lay there 10, maybe 20 minutes. Sometimes it takes a while. They'll get up and they'll start to feel lightheaded again, put them back down, keep their legs elevated. Start with oral fluids, get a weight on them. If they're significantly dehydrated, think about giving them some IV fluids. They're more than 5%. They're nauseated, can't take the oral fluids. Think about giving IV fluids. Now, muscle cramps is an interesting and sort of controversial area. And again, as I mentioned, we see muscle cramps in Kona like I've never seen before. And I've taken care of a lot of American football players in the heat in Southern California, so I've dealt with a lot of cramping. We know that the essential feature of muscle cramping is muscle overload and muscle fatigue is when they occur. But we also know, particularly in hot and humid conditions, the loss of sodium can contribute to the development of muscle cramps. And for that reason, we see them occurring much more commonly in races done in hot and humid conditions. Other risk factors for cramps include increasing age, higher BMI, athletes who do not stretch, running up hills as they become more and more fatigued and increase the intensity. Those are all risk factors for the development of cramps. I think we've all treated athletes with cramps, and we've probably all had them ourselves. We know that we start by just putting the muscle in a lengthened position. We often try icing and massage. But again, in the medical tent in Kona, we see these cramps like I've never seen. My shins are cramping, my thighs are cramping, my calves are cramping, my forearms, my hands. I've never seen anything like it. And when we get these sort of total body crampers, we've had great success using magnesium sulfate. We actually put anywhere, usually 2 grams in a bag of IV fluid. You got to run it in slowly. You don't want to push this in because it'll cause hypotension, but we see athletes getting really good relief from using mag sulfate. Sometimes if the athlete's very anxious And very severe crampers will use a little bit of Valium. But the key to preventing these, and often in the acute stages, is giving them added sodium. And a trick that I use oftentimes in my American football players, at the first sign of cramp, take a teaspoon of salt, mix it in 8 ounces of a sports drink, and have them drink that as quickly as possible. Often can ward off cramps. And by having athletes try to ramp up their sodium, you can do a lot to help try to prevent them. Now, heat stroke is the key to recognize that you cannot miss this, because when it's recognized and treated appropriately, these athletes do very well. It's when it's missed that this can have fatal consequences. You have to be on the lookout for any significant change in mental status. Often it's associated with an athlete collapsing, either a loss of consciousness, an altered level of consciousness, or what I'd refer to as mental stimulation. They're just acting out inappropriately, talking inappropriately, can be signs that athlete is suffering from heat stroke. When you combine that with a rectal temp above 40, that's how you make the diagnosis. And again, as I mentioned, it's rare to see it in Kona. We've only had, since I've been there in 20 years, maybe 2 or 3 cases of athletes where we've had to put them in an ice bath. It's more likely to be seen in the end stages of a marathon done in a hot, humid environment. And that's where you're likely to see it. Or in a American football game where they're wearing lots of pads, where we typically see it. Now, this is the 1984 Women's Olympic Marathon. This is Gabriella Anderson-Zueiss. Probably many of you have seen this footage of Gabriella well back in the marathon, struggling to cross the finish line. This is one of these cases where, what do you do with an athlete who simply will not stop? It's the Olympic Games. She's certainly not going to win this race, but look at that look. She looks just like Jim Peters. In fact, the commentators mention Jim Peters. This happened to Jim Peters, and he never ran another marathon again, and never did Gabriella Anderson-Zueiss. Never ran another competitive marathon after this race. Actually, one of the guy on the right here, the athletic trainer, is one of my patients, and she had 108-degree rectal temperature. They cooled her, and she survived this and did fine for the most part, but was never a highly competitive marathoner again after this incidence of heat stroke. Now, what are the risk factors for heat stroke? Well, the environmental conditions primarily, high heat, high humidity, that's where you're likely to see it. Again, the speed the athlete runs, the faster they're going, the more heat they generate, the more likely you are to see heat stroke. We also know that there's a large degree of individual susceptibility, and the fellow shown here is Kory Stringer, who was the first heat stroke death in the NFL. And Kory every year had problems with the heat. It was known that he would struggle during the 2-a-day football practices held during their spring training camp, during their summer training camp. We also suspect, although it's hard to prove this, but in my mind, I believe that athletes who are dehydrated probably are more likely to suffer this. But we know that just because you're drinking, don't think that you can't suffer from heat stroke. We know cases where athletes have been hydrated, have been drinking, and still suffered heat stroke. Obviously, the more things you put on your body that impede loss of heat, like football pads in American football, significantly increase the risk for suffering heat stroke. Now, the Kory Stringer case is a tragic one. He died in July of 2001. The Minnesota Vikings hold their summer training camp in Mankato, Minnesota, and this day was an amazingly hot and humid day in Minnesota. In fact, the heat index that day was so high that there's a law in Minnesota that you could not keep cattle outside. You had to put them in shade. But there was no law banning the Minnesota Vikings from holding 2-a-day football practice. Now, this picture of Kory Stringer on the left appeared in the local newspaper, and it was picked up by the AP Wire, sent all around the country, a picture of him vomiting during practice the day before. This is a warning sign for heat stroke. Often nausea, vomiting, diarrhea are prodromal symptoms that suggest heat stroke. You need to take that seriously when athletes have these GI symptoms. This is the critical moment when Kory Stringer collapsed, and the coaches said, leave him alone. He's just faking it. He's a big baby. Leave him there. That if they had put him in ice water, Kory Stringer, I have no doubt, would be alive today. But they missed this critical window. They allowed him to sit here for several hours with a rectal temp of 108, cooking his insides. And by the time Kory Stringer got to the emergency room, it was too late. He was already developing DIC and died in the emergency room related to complications from his heat stroke. Now, I found this ice water cooling effects amazingly dramatic. Athletes rise from the dead when you do this. And I got this experience, actually, I believe Bert Fields was with me this day in 2004 at the Marine Corps Marathon in Washington, D.C. We had a very hot and humid day for October in Washington, D.C., and we had at least 7 or 8 cases of athletes coming in with rectal temps above 107, just in extremis. And you can see this athlete being brought in on a gurney, and they immediately recognize the heat stroke. You can see his rectal temp 107.2 at that time. We have a rectal thermistor. We use these in Kona as well. You insert it into the rectum. You can watch that temperature come down, put them in a bucket of ice, and watch that thing drop. If you don't have the thermistor, it's very nice to have, but the way I do it is put them in the ice till they start shivering. Usually once they start to shiver, they've been cooled enough. If you put this athlete in an ambulance, they will die. Because by the time they get to the emergency room, they're not going to have a tub this size to submerge them in water. So if you're working at an event and you suspect heat stroke, you got to do this. You can't miss that window. You call an ambulance, you may be sealing that athlete's death by missing the window. And this is how it's handled. Really, it's a heat attack. This is an emergency that you cannot miss the diagnosis. You put them in ice water, they walk away doing fine. You miss it, they end up in a morgue the next day related to complications from heat stroke. But this is how very organized at the Marine Corps Marathon. I really learned the key to managing heat stroke, seeing this firsthand, how these athletes do when they're appropriately managed. So think of thinking heat stroke. When the collapse occurs prior to the finish line, in most cases, there's an alteration in level of consciousness, mental status, rectal temp above 40, they automatically go in the ice water. Often they'll have elevated heart rate, decreases in blood pressure. Typically 5 to 10 minutes is enough until they start to shiver or until that rectal temp comes down below 38. That's when you take them out. The keys to prevention with heat stroke: athletes need to acclimate to the heat. Typically, the first couple of days in a new environment are the highest risk for these athletes, and we often see these in the football players in the preseason camps. I believe dehydration probably contributes. I think it's useful to get daily weights on these athletes and be watching athletes who are progressively losing weight over a period of several practices. A history of heat stroke, as I mentioned, Kory Stringer, that's a big red flag. Always be watching. An athlete has it once, they're likely to get it again. And keep in mind the GI symptoms: nausea, vomiting, diarrhea, often are prodromal symptoms, warning signs that that athlete could have impending heat stroke. And this is a heat attack. You need to cool them first, transport them second. Let's move into the dangers of drinking too much. Hyponatremia of exercise. I think we've all heard about this, and this is really nothing new. I mean, we've known forever that water can be life-saving, but it can also be lethal if taken in inappropriate doses. And this has to be proven over and over again. And this was a very tragic case in January of 2007 in Sacramento, California. Some very stupid radio morning show disc jockeys decided to have an on-air contest that they called Hold Your Wii for a Wii. And if you're familiar with the Nintendo Wii, then was the hot new video game that all the kids wanted. And they were offering to bring in a group of contestants into the radio studio, have them drink as much water as they could. And the last one who didn't have to pee, if you had to pee, you were eliminated. Those who could hold their pee the longest and not throw up won this video game. So they had a string of contestants come into the radio station, enter into this contest, and right away, as they started to run it, they got a call that they put on the air, amazingly, from a nurse. And listen what she had to say.
Eva?
Yes.
What do you want to say?
I want to say that that those people that are drinking all that water can get sick and possibly die from water intoxication.
Yeah, we're aware of that. They sign releases, so we're not responsible.
It's actually right from the radio show.
If they get to the point where they have to throw up, then they're going to throw up and they're out of the contest before they die. So that's good, right?
Oh, that's me. I suppose so.
Yeah. All right. How come you guys didn't do it?
Thanks for looking out, though. We don't want to die.
Oh, okay. Let me ask Carter if anybody's dying.
We ain't dying.
Hey, Carter, is anybody dying in there?
We got a guy that's just about to die.
It's a bit difficult to listen to this because they're joking and laughing.
Get the insurance on that, please.
But they did have a contestant who was about to die. It was Jennifer Strange. She was a 28-year-old mother of 3 who entered into this stupid contest trying to win one of these Nintendos for her kids. And she almost won. She drank nearly a gallon of water. She finished in second place until she finally got so sick she could not take anymore. And here they interviewed Jennifer Strange. This is what hyponatremia sounds like.
Hello.
Jennifer, I heard that you're not doing too well.
My head hurts.
Oh.
They keep telling me that it's the water, that it'll tell my head to hurt, and then it'll make me puke. But
Who told you that? The intern?
yeah,
That's what I noticed over there.
like it hurts, but it makes you feel lightheaded. So I'm not sure if I'm just like.
This is what it feels like when you're drowning. There's a lot of water inside of you.
Oh, it hurts.
This is like Deep Blue Sea. So we want to get you out of your misery.
Again, really sad to listen to, but Jennifer Strange was allowed to go home. They found her dead 3 hours later, related to brainstem herniation from hyponatremia. So we know that too much water drinking can be dangerous, and we see it in the setting of an endurance race with a dilutional hyponatremia, when an athlete drinks too much of a hypotonic solution, and this excess body water relative to the sodium dilutes out the sodium and can cause the same problems that we saw in Jennifer Strange. Typically, it's related to weight gain, fluid overloaded. That's why it's so important that we measure weight pre and post in these athletes. And we also see in Kona, interestingly, cases where the athlete is actually dehydrated and hyponatremic. They've actually lost salt and water and only partially replaced the water. So it's not always the case that they're dehydrated or that they're fluid overloaded. We see cases where they're actually dehydrated and hyponatremic. Now, why does this happen? Well, we think that prolonged exercise impairs the kidney's ability to excrete urine. We know that when you're fluid overload, that the antidiuretic hormone, ADH, or arginine vasopressin, should be maximally suppressed in the face of that fluid overload so that you are allowed to pee it off. But probably because of pain, perhaps ischemia, there's a reflex that causes the athlete to hold on to that water inappropriately. It's a syndrome of inappropriate ADH, SIADH in this case, because a normal kidney should be able to excrete 800 to 1,000 cc's of hour, more than enough to protect an endurance athlete from hyponatremia, but it doesn't occur in these cases. Now, this was really brought to the national media attention in 2002 when there were two really high-profile deaths related to hyponatremia in marathon races. The first occurred in April of 2002. Cynthia Lucero died in the Boston Marathon, and then tragically Hillary Bellamy in October died in the Marine Corps Marathon. And both of these women fit a similar pattern. They were amateur racers, both women, that were running for a cause, something sort of bigger than themselves. You know, one was running for Team in Training, breast cancer, raising money for breast cancer. One was running for the AIDS Foundation. Both had signed up lots of people to give them money and probably pushed themselves beyond what they normally would have. And what typically happens, the athlete, as they begin to feel poorly, they think, I must be dehydrated. I have to pound more water. So we have to tell these athletes, particularly the amateur athletes, you need to have a hydration plan and stick to it. If you start feeling bad, try not to deviate from it. If you start drinking more, that's where you're going to get yourself into trouble. Now, what are the risk factors? As I mentioned, those two sort of fit the classic pattern, but drinking too much before and during prolonged exercise will cause this. We see it more commonly in females and those who are running slower because they're often sweating less and have more time to drink. We typically see it in the extremes of temperature, particularly hot, humid, but also cold weather conditions where you're not sweating too much and you're drinking more than you should. Also, the availability of hypotonic drinks. We put more and more water out there. We're going to see more cases of hyponatremia. We also know that certain athletes are very salty sweaters, and you'll see this on the running shorts of certain athletes where that salt is just caked. We know there are large variations in how salty these athletes' sweat is, and we think that some of these cases may be due to subclinical cystic fibrosis. We know that 4 to 5% of Northern European adults are carriers of cystic fibrosis. In fact, this woman here, Lisa Bentley, is a professional triathlete from Canada who runs Kona, one of the top triathletes in the world, and Lisa suffers from a mild case of cystic fibrosis. And every year she would come into the tent early in her career with very low sodiums, but a very bright woman. She's been able to figure out how to take salt pills and sodium containing drinks and is able to manage her sodium in the face of her cystic fibrosis. Now, what are the symptoms of hyponatremia? There's a wide variation, and they tend to correlate with the level of the sodium, but it's not always the case. I see time and time again athletes with very low sodiums who are not that symptomatic, and others who, at the same sodium, are dramatically symptomatic. Now, we know a normal sodium ranges from 135 to 145, and typically, as long as you're above 130, you don't usually see many symptoms. But once you start to drop below 130, often you start to see GI symptoms with headache, nausea, vomiting. They often feel very fatigue, malaise. When they've drank too much, they'll often feel bloated and puffy. And when you start to drop down below 126, you often then tend to see athletes becoming confused, disoriented. They'll experience what I call phantom running. I'll show you a clip of that in the next slide. As it progresses, they'll develop respiratory stress, lapse into coma, oftentimes have seizures, and death in these athletes is typically related to brain swelling, which causes an increase in intracranial pressure, causing brainstem herniation. And once you get the blown pupil, you know the game is over, and that's the cause of death in these athletes. Now, invariably, once they pass a large amount of dilute urine, these athletes feel better and can leave the tent. Now, this is that phantom running that I've seen over and over again. The athlete doesn't even realize they're doing it, and until the sodium corrects, and we've given them Valium, we've done all sorts of things, nothing helps us until they finally have to pee, and sometimes they just have to lay there for a few hours. The critical thing is don't give these people IV fluids. You have to know they're fluid overloaded and restrict their fluids. Now, we assume they're hyponatremic if they have some alteration in their level of consciousness, but the vital signs and the temperature especially are normal. The key differential in this is rule out heat stroke. So if the rectal temp is normal, I assume hyponatremia. Now, typically the vital signs differing from heat stroke are going to be stable. The blood pressure, heart rate, and you look for the signs of fluid overload. Their fingers are puffy. Their wrist is puffy. They've gained weight is the key thing. You got to be able to check sodium levels in these athletes. And the first priority, if they're fluid overloaded, you cannot give them IV fluids. And in fact, when the symptoms are significant, and in general, anybody who's significantly symptomatic and hyponatremic, and anybody who has a sodium 125 and below, we use hypertonic saline. And we'll infuse 100 cc's very quickly. We may repeat that 1 or 2 times in athletes who are significantly symptomatic from hyponatremia of exercise. I want to end by just mentioning what tends to get these athletes into trouble, what I call the will of the endurance athlete. Take a look at this clip. This is Natasha Badman, 2003 Ironman. She's one of the top female triathletes in the world. She's 4 miles into the marathon. She peels off to the side, vomits 4 times, wipes the barf off her face. She won this race. So, anytime in my endurance career, when barf touches my list, the race is over. That's not my reaction to throwing up. But these athletes have this ability to push themselves. A guy like Chris Legh with bowel ischemia who keeps running a race, this is often what gets these athletes into trouble. This ability to just not notice pain, which would cause most of us to stop doing an activity they simply ignore. And this is what often gets them into trouble. And Roger Bannister said it best, the notion that courage and esprit de corps can somehow defeat the principles of physiology is not only wrong, it's dangerously wrong. And I think we see this in all of our elite athletes, this ability to push beyond where they should push, to know what that limit should be. So let me conclude with just a few take-home points that I think summarize what I've had to say, that collapse very common in athletes who are engaged in vigorous activity from triathlons to football in hot and humid conditions. Now, in my experience, it's flawed plans for hydration and sodium balance that typically underlie most of the common causes of collapse. And just based on that, you can almost predict what is going to happen to that athlete. When you're dealing with collapse, a proper assessment is essential. Typically, collapse is more likely to be benign if they collapse after the finish line, the vital signs are normal, and they're awake, alert, and talking to you. On the other hand, you should always have heightened level of concern when the collapse occurs before the finish line, the vital signs are unstable after you've laid them down, elevated the legs. If the pulse stays up, the blood pressure does not come up, you got to be more concerned, and particularly if there's an alteration in the level of consciousness that's not clearing up, be suspicious you're dealing with a more serious sign of collapse. Always keep in mind the weight gain. Do not give IV fluids to somebody who's gained weight. Treating that appropriately will go a long way to preventing some of the catastrophic things that we rarely see that could be prevented. And I'll end with just one more case of collapse here, a little more comical. Thank you very much. Happy to take any questions.